I'm delighted to have this fireside chat with Doug Melton, Global Chief Commercial Officer of Human Capital at Aon. And the title of this fireside chat is Beyond the Prescription, What It Actually Takes to Implement GLP-1s. So, Doug, you and your colleagues advise some of the country's largest employers on a wealth of decisions that are shaping really a lot of big decisions for people and their health. So we're going to talk about that, and we're also going to talk about just how important employer engagement is to what the GLP-1 landscape. So we have lots to talk about, but we did want to have a little bit of audience engagement. So I wanted to this was Doug's suggestion, so if it goes down south, Doug, it's all you, okay. So just if you would raise your hand, we wanted to just get a sense of where you're sitting within your own respective organizations, where you are today with GLP-1s. Are you at a place that is not covering GLP-1s? Raise your hand. Wow, okay. Are you at an organization that is still grappling with evaluating coverage? Okay. Are any of you at a place that are covering with restrictions? Okay, seeing some hands up. Are you at an organization that's covering with wraparound support? And how many of you are not sure and don't really know? Okay. All right, second question. Okay. Do you want to react to what you just saw with hands raising yet, or?
I think there are only two in the back in which is not currently being covered. I should ask who your employer is, but we won't.
All right, so I also want to ask a second question about barriers. So many of you in the room are decision makers, or you're trying to be decision makers and driving action. We want to hear about some of the biggest barriers that you're facing for a sustainable strategy. How many of you would say that drug cost is a big barrier? What about eligibility and learning about coverage design? Okay. How about wanting to know about adherence and discontinuation? Is that a barrier on your mind? What about outcomes data? Do you feel like you don't have enough data to be able to make decisions? Okay, and then the last one, lifestyle and clinical support. Is that a barrier? Okay. All right, well.
We got more hands raised for that section, so that's good.
Okay.
That helps out a lot. And again, the context for what we're going to talk about today are best practices through the lens of the employer. So that's why we want to ask you those questions, kind of where are you at with your current employer, and just make sure that we tailored our commentary directly to kind of what you care about. So that's helpful.
Okay. So let's get started, but Doug, I think it's so interesting where you work, your role, sort of how you're coming at it. So I always like people to understand who they're hearing from. So can you just talk a little bit about who is Aon, why they're so invested in employer engagement and health, and what exactly are you doing in this space?
Yeah, so we are specifically focusing on solving workforce problems. I like to tell people that I grew up in a lab with a petri dish, but now my lab is people versus chemicals. And that's a true statement. So specifically what we do is we go to front of CFOs and CHROs, and we help them across three things. How much should you be paying your people? So compensation. How do you think about health and benefits for your workforce? And then the third thing is how do you think about retirement, right? So those are the conversations that we have with our clients, multinational clients, not just those here in the US. And you'd be surprised how disconnected many of those companies are, because the person that owns retirement doesn't actually work with the same person that owns benefits. But the reason why there's the largest airline in the globe right now the employees are having higher disability rates and they can't retire, it's because they can't afford their health care. So they're directly connected, and that's what we try to do, is solve workforce problems.
That's great. Okay, so let's start talking about sort of the context of GLP-1s in the sphere that you operate in. What are some of the biggest operational decisions that Aon is facing, that you're trying to help your clients with? Tell us what those areas and buckets are, and then how does that relate to GLP-1s?
Absolutely. So we'll make it fun. We won't call them barriers, we'll call them traps. Because we've been in this for 3 or 4 years now, so we kind of know the traps. I'd say trap number one is really understanding the how restrictive or unrestricted your relationship is with your PBM. Again, how restrictive or unrestricted is that? If it's really unrestricted and pretty much anybody can get it, diabetes, weight loss, other type of side effects that they want to just solve for with this therapy, then the rebates are going to kind of like not be an issue. If you decide to kind of make it a more of a restricted coverage and say, hey, no, here's the profile of the employee that has to be able to get it, then you're going to have challenges with the rebates. And so the first one is really understand what your contractual relationship with your PBM in the context of a restrictive or unrestricted network. And the reason why you really care about that is as soon as one employee finds out they're not eligible for it, all of a sudden now it's going to be posted on Facebook and you're just going to get 1 million views. And so that's why that first one, bit trap, is good. The second trap, and many of them have talked about it, and Dr. Jeffrey and many others earlier today, is not just to focus on the therapy as a silo, but you got to put a lot of wrapper services around that. We love to talk about the success stories and say simple things like mental health. They talked about exercising and lifting weights. I probably should do a better job of lifting weights, and I'm a male. But one of the things we don't talk about a lot here is for people that become non-adherent or go off of it. You don't hear that success story. No one ever talks about the unsuccessful story about the employee that's not sleeping at night because that's an adverse effect that they're having. No employee actually talks about the psychotraumatic effects they now have from it because that's just not a use case you're going to see picked up in the headlines. And so when I say the wrapper services, that's a very important to say, how am I going to think about this for those that are going to be adherent and use it? Life, diet, and exercise. And then for those that decide to come off, or just those that have adverse side effects, what's that program like as well? That second question, a lot of large employers don't have. And then the third trap is specifically focused on evaluation. So at one point, you got to measure it and say, hey, how do I think about the outcomes beyond just medical costs? But we'll talk about some of those later. But that's a third trap. If you've got to show your CFO our ROI savings at 9, 12, or even 24 months, that's going to be difficult to do if you're just looking at medical and pharmacy costs. We can help you look at other benefits to the organization as well. So that third trap around proving it to your CFO or to your board of directors, that would be a third trap to think about.
Is there a standard set of wraparound services yet, or is that evolving? Like when you say that, what's in that basket, and who's defining what that is?
That's great. And by the way, that was not a prepared question from Sarah, so I don't have a prepared answer. But here's what I will tell you. The answer to that question depends on the budget of the client and the job types of the client. Today, we've talked very high level about just workforce and population health in general. But I would answer that question different for the Miami-Dade County school system, which is actually one of our clients, versus what I would do for FedEx. Two totally different groups. Miami-Dade County school system, 2/3 of the population is multilanguage, 2/3 of the population are first-time generation in North America, and only 1/3 of the population has more than a college degree. Where if you go to FedEx, that's completely opposite on the inverse. You've got labor, you've got unions, you've got mostly a U.S. population and mostly male population over the age of 50, and they're highly dispersed throughout the country and throughout the globe, whereas Miami-Dade County is all in one place. And so for wrapper services in Miami-Dade County, you could do on-site health services. You could set up a network with Mayo or other groups around here and make something very localized. But then when you have a multinational client, like FedEx, then the conversation is different. So the wrapper services look different. They start to become more virtual, and you have to get highly into hyper-personalization. And hyper-personalization is going to be more relevant to a group that is sparsed out versus one that is local.
So that's a great bridge. I wanted to talk about ROI next, and how do we model that? And when you and I were talking, you don't want to just pin a number and say there's a number. There's a lot of considerations that go into defining ROI and measuring it. Why don't you tell us a little bit about how you approach that in your work, and then if you have any best practices that you want to share with this group later, we're going to want to see if you have any best practices or lessons learned that you want to talk about as well.
So both of the physicians that were just on stage who did a fantastic job, and one of the things they said is, still too early, still too early. I 100% agree with them on that. And so what we were able to do is look at 192,000 working employees across the country, not just Aon colleagues, but just 192,000 commercially employed individuals, and we started looking at leading and lagging indicators. Do you see readmission rates go down? Do you see ER rates go down? Do you start to see more people being adherent to things like Crestor and Lipitor if they have hypertension? So we were looking at those things, and what we essentially found was at about 12 to 18 months, you do start to see lower admission rates and lower readmission rates, which gets you to some savings. And then by year 3, you actually start to see where the total cost of care goes down for the individuals that are adherent versus those that are not. We define adherence as 80%. So 80% of the time you were taking your therapy versus a control group that looked just like you that didn't take their therapy. We didn't start to realize those savings until, again, years 2 and 3. Once you factor in the cost of the actual drug, those savings unfortunately become flat. Those savings become flat. And so what we've been sort of guiding individuals are, if you want to see an ROI in terms of net return for medical cost savings, you can do that at 12 to 18 months. If you want to see net savings, you have to look at that at a 3-year period, and you have to consider the cost of drugs when you actually do that. So that's a very hard pill for a CFO to swallow, telling them they're going to have to wait 3 years to see something that is driving their medical trend. For some of these companies, guys, it's going up 18 to 20%. And if you have a $500, $600 million budget, where a lot of my self-insured clients have, 18% of $500 million is a lot of money. And you start to divest into things like compensation and retirement. So that's the short answer to your question, is we start to see those savings over time in that 2nd year and in that 3rd year. But unless we can figure out how to bring the cost of GLPs down, it's going to be really hard to prove the long-term savings.
Great. Okay. And so we've talked all morning about the importance of adherence. So, just want to state it again that GLP-1s are intended to be long-term treatments, and that it's important, and the science is saying that most patients need to remain on the therapy to maintain the health benefits. So we know that on top of costs, the discontinuation by users is a key concern. Just wanting to know if you can validate that or amplify, like, what are payers and employers feeling about adherence? And then really want to hear and learn from what Aon is doing. You guys have done some incredible studies around GLP-1s. You're releasing a lot of data. And this could be a driver of value. So just would love to hear anything that you'd like to share with us around adherence.
So you guys have heard a lot of stats today, and I've tried not to overwhelm you with stats. I'll just open up the answer to this one. Folks between adherence at rates between 50 and 79% have about a 3% reduction in medical costs over that 3-year period I was describing. Folks that were adherent 80% or more have a 7% reduction. All right, and so it's just significantly greater, again, confirming what these gentlemen said earlier on stage, that remaining adherent is important, not because it's important, but because when you bring that weight loss back, the strokes come back, the heart attacks come back, et cetera. And so that's why adherence is important. So let's talk about adherence, because it's not the first time we've talked about this. We've got people having strokes every day, not taking Crestor and Lipitor. We have people having diabetic comas every day, not taking their insulin. So what's new about this? We've kind of done 3 things to make sure adherence gets to the top of the level. And I'm keeping it 3 so we don't have to write it all down, thanks to ChatGPT, who's transcribing this conversation. The first one is ask employees what they want. How do they want to receive it? Help them understand what kind of titration rate is the right one for them. Majority of times I ask clients, say, Doug, I want to launch GLP. We want to make it available on our coverage. They jump right to price. And I said, well, have you asked your employees, do they want to do this? And if they do, how do they want to receive it? So that's question number 1, just asking them. The second one is you have to make it easy for them. And so endorsing eMed in this case, eMed makes it easier to be adherent because you can be at home and do the remote monitoring that you need to do, et cetera. So number 1 is ease. And then the third, which we've all hit on here before, is the price. They say $80,000 with the median. I would probably challenge that. I can't say stats empirically, but I know the majority of my clients, the median wage is not $80,000. I'd say that, not North America. So I would say cost would be the third one. So we want adherence to be better. One, make it hyper-personalization. Two, make it easy. And three, make it affordable. Now, those are all simple answers a consultant can say on stage. Implementing that is really hard to do. So that's why I'd say start with that first one, which is just asking the employees how they want to receive it. And then at some point, you're going to have to sort of change your campaign based on the subset of your population. A call center employee is going to want something much different than a person driving a truck 8 hours a day picking up trash.
So you've done a lot of work over your career around ROI, and I want to hear more about sort of the workforce aspects of ROI. You and I had talked about like some buckets that are really important. You know, it's so easy to jump to certain metrics like savings from hospitalizations, but there's so much more.
Yes.
So can you unpack that? Let's just step way back. What are those buckets? Why are they important? And how can these be part of the ROI equation here?
Fantastic question. So we're going to finally talk about something outside of healthcare today, which is great.
Okay.
I'd say those, I love threes, you can tell by now. I'd say those buckets are, and we're not going to Switzerland to present the results, but we're going to be presenting them pretty soon in North America. We're looking at three buckets. The first bucket is absence. So think short-term disability, FML, long-term disability, extended leave. The second bucket is around performance. So we actually have a handful of clients today that are giving us their information saying, I'll let the actuary tell me whether or not the underwriting makes sense for the ROI. I want you to show me that because this employee now is less weight and has more presenteeism, that their sales ratio is higher or they're building more widgets, et cetera. So we're looking at performance. And then that third bucket we're measuring is retention. And I would say, guys, out of all three of those buckets, the absence, the performance, and the retention, the one we get the most questions about, I was telling Sarah this the other day, was it's the retention one, it's the turnover. Because if I just told you you're not going to get the savings to year 3, and you leave one big brand retailer, making up Target, not one of my clients, and go across the street and go work for Walmart the next day, you're essentially, they're investing in you to get healthy at one retail organization, and you're going across the street working at the other one. So that retention one is starting to become really, really sticky, where they're saying, I want to do, not quite eMed performance guarantees, but I want to almost say that if you get on this and we approve this coverage for you, you have a 2-year minimum that you have to stay with us. And so what a lot of our clients have decided to do is say, year 1, they can't do the inverse because ERISA doesn't allow you to do that, but they do the opposite of it, which is to say you work for us for 12 or 24 months, and then at year 3, you'll be eligible for the coverage. Some clients are more liberal and they'll say, work for us for 3 months, and then in months 4 beyond, you can get it. But they're kind of using sort of this front end, what do you call it? A front-end time clause to make sure that you're kind of loyal to the company before they approve you for the therapy. So that's what most of the clients are doing right now. But again, this is very important to talk about because the bigger opportunity for savings here is in the performance and the absenteeism space, much bigger than the healthcare one. And very little research is focused on that today, which is why you'll notice Aon, I'm not advertising Aon, but just saying, that's why Aon's kind of moving out of that space, working with some academic partners to start to measure that, and it all starts with the data. Because if you then go to a large employer today, and I won't start dropping names, and you ask them, give me all your top 100 employees' performance data, give me their absence data, and then give me their turnover data, they'll say, we'll call you in 2 years, Doug, because that's how long it'll take to get it together. And so a lot of this is integrated in a data strategy, and it's really waking up a lot of CHROs to their CFOs, and their CFOs are looking at CHROs saying, how do you not have your data integrated to evaluate all these investments you're making in your employees? And so it's really changing the conversation to be oriented in analytics and measurement versus just talking about GLP.
That's great. So, you know, you've just made the case about the need to measure and collect that data. Do you want to say anything more about, like, once you have that data, do we have the platforms and the systems to analyze it and get it out there? I mean, what are we going to do with that data, and who are we going to share it with?
Yeah, I think fundamentally, before we even get to those 3 outcomes data, we've got to have a plan around adherence. Today, adherence is measured differently across different organizations. If you are UVA, you might want to measure it because you actually have a hospital there, so you can have people to process the labs. If you're not UVA and you're a corporate company, which a lot of my clients are, you've got to get that information request or LabCorp. But what if your employees don't want you to have that information from Quest or LabCorp? Then we have to get it from your medical claims. But your medical claims assume that even though it was administered to you, you don't know if you actually injected yourself with it. So adherence right now is incredibly difficult to measure, and we're trying to come up with a systematic way to do that. Again, companies like eMed have tools to do that, but even eMed requires the employee to intrinsically be motivated to upload their values into their tools every single day. So we're working through sort of creative ways to be able to effectively measure adherence in this world of different data assets.
Very helpful. So if I'm a benefits leader and I need to go to my CEO tomorrow and I have a GLP-1 proposal, are there some non-negotiables that I should be building into the program? I mean, we all want this to succeed, but I think a lot of people are grappling with how do I make this case to the CEO, and what are some parameters that I should be thinking about?
Okay. Anyone making the pitch to the CEOs? Because I think you guys all have them now. I think number one is to have a clear plan, because employee dissatisfaction, employee sentiment will kill a company's culture, and if you lose a company's culture, then you lose the effectiveness of the company. So I've never seen I've never seen a topic that's been so decisive. Even when a few years ago, we had the whole DEI in terms of equity component of it. Then we had the debate about work from home. Then we had the Great Resignation. I mean, we've had all these trends just in the last 5 years that have impacted the workforce. But this one, whether or not I am an employee and I am covered for the GLP, creates either loyalty or the decision to leave. And happens relatively fast. So the first one is you need to set up a clear plan on who's included and who's not included, and then you need to start teasing a communication plan out there to say, is this the right way to communicate this decision that we've made? So that's point number one with your CEO before you even jump to a business case. The second outcome, the second thing in your business case to the CEO, you need to get that CEO comfortable with measuring adherence as an outcome. If we take nothing away from today's session, adherence, adherence, adherence. The individuals that need to be taking this therapy that are cardiometabolic, that have heavy rates of cardiometabolic syndrome, are not taking therapy today, guys. They're not. They're not. I won't jump into some of the characteristics that some of the people on stage have described, but they are accurate. The people that should be taking this, that are going to drive your highest hospitalizations, you're going to drive your highest readmission rates, are not taking this therapy. A lot of them for cost reasons, just to be honest. So your second bucket has to be, we have to focus on adherence. We need to have quarterly updates on adherence rates. When people are not adherent to the medication, we need to ask them why. We need to set up step therapy programs for them, whatever needs to be here. But look at adherence as an outcome as much as you look at cost. And then the third thing to get to cost is make sure that when you are measuring success and bringing that results back to your CEO, you're looking at all aspects of the workforce savings, again, absence, disability, et cetera, not just the cost of the therapy itself. So those would be the three things: clear plan on who's getting covered, and a relentless focus on increasing adherence. And then the third thing is looking at ROI beyond just medical costs.
Great. That was great. Thank you. Okay, so we want to open it up for questions in a second. So get your questions ready, or comments or experiences that you want to share. But Doug, you're just a wealth of information. Is there anything that I didn't cover that you think is missing here as part of this conversation? Is there anything around implementation and moving beyond the prescription that you didn't get a chance to share with the group?
I would love to hear from our audience.
Okay. We will have a running mic coming around if you are interested in asking a question, but this is a chance for some really good free advice. All right, we need a mic over here. I think they're coming. Okay, maybe use your voice.
My outside voice. Doug, I love the incentives that you were kind of talking about and the whole way that you approach this issue. Can you talk a little bit more in depth with all of the studies and data that you have on more high turnover industries and, again, making that argument for the right client?
Right. I will do that. My team would be remiss. I'm glad you said the data. My team would be remiss because I didn't talk about a lot of adverse outcomes in our studies. So let me answer that, and then I'll talk about the industries one. I think the two adverse outcomes that we're seeing is for women, we're seeing high rates of gallbladder removal, because any clinician knows, a lot of them in the room, that if you lose weight like overnight, gallbladder becomes an issue. So that's been a really big issue for us. And the reason why that's relevant is gallbladder removal is also associated with extended leaves. So that's been an adverse impact of this, and it's statistically higher, almost 3.5 times higher for women than for men. And then on the men's side of the house, one adverse effect of this has been, I won't say overuse, but this is, for some reason, more men are now using behavioral health services than they ever did before, but the use of the services has become, like when they start using, they just almost get addicted, and they use more than the two they're sort of covered for in a month. So I won't say that's an adverse impact, but it's driving mental health costs up higher than it has before, and men are almost using this as a way to that. So that's just that one. As you think about industries, I would say that for public sector groups, that you need more wrapper services than you probably need for financial services and tech companies. Financial services and tech companies have been approving this since the beginning. They also have higher rates of discretionary income to be able to give you more resources in a virtual setting, and they're also higher adopters of virtual services. And so just to separate those, that'd be three: public sector, more in-person, less discretionary income, and hyper-personalized. Financial services and tech, we're finding can be more virtual, not as hyper-personalized, and you don't have to invest as much in the wrapper service because they have discretionary income to do the things they want to do, like gym memberships or food subscription services, et cetera.
Other questions?
Yes.
As part of your strategy when you're talking to different companies, because it's very popular to turn something on and then panic when you see the costs coming in and then turning it off. Do you recommend, 40% of America is obese. Dwayne "The Rock" Johnson, before he lost all the weight, was the BMI of 34.
Yeah.
I didn't consider him unhealthy. So, but 10% are over 40%. Are over 40 BMI, and 20% over 35. So do you recommend maybe a strategy of maybe taking that spigot, regardless of the loss of rebates, and maybe starting at a 35 BMI, or starting at a 32 or a 40, and then seeing how it goes from there, and then start to turn the spigot on, rather than putting a plan in BMI under 30, over 30, having to run to the bank, and then having the CFO fire you?
Yeah. Yes. So two strategies that I have when you're coming out of it. One is to set your BMI threshold. So that's one to actually do. And again, to do the math behind what's associated with 30%, you said 31 versus 35, because sometimes it's pretty big savings. The second thing I suggested, which has been really helpful, is to just do small group rollouts. There's a very large credit company where we just picked 2 call center offices versus all 15 they have in North America and India, and rolled it out there and saw what were the pain points, et cetera. And then there was a school system that we did it for, in which we picked 1 high school, 1 elementary, 1 middle school, and just tested it with them and said what were the results for those teachers before we rolled out with the whole school system. Those plans usually work really well. Again, the downside of that is then all the other 14 high schools and the other 13 middle school teachers were all complaining that they weren't part of the pilot program. So there's a way to do it. But I do think sort of picking a threshold either through BMI or picking a threshold through who you see are getting admitted to the hospital, or picking a work site would be the way to slowly drip into this. A pivot to answering your question that I did not say when I was talking earlier would be, and it's fine because they're benefit managers, don't always understand drug pipeline and drug pipeline development. And what unfortunately has been happening is that you've got more and better GLPs, if you will, coming out, like we're about to have a 3 agnostic one. You set up a benefit and a formulary for that upcoming year for basically a GLP that it's outdated and it's less effective. And so nobody's actually enrolling in the program because they want the new one that came out in March, but you made your benefit decision in the summer of 25, and so the March of 26, you can't use it. You might be available now 1/1/27. So we've been asking a lot of our clients, we've been kind of just sporting them when pipeline comes out, saying, hey, as you're thinking about this, you might want to wait because there's a 3-tide, if you will, that's going to be available by 1/1/27, that the FDA's trials are going really well. And so that's something, and again, I'm not expecting a benefits manager, Marshall, appreciate this, to understand pipeline development, but it is important in this space because of the rapid progression that we're making.
Other questions over here?
Yeah, I'm the CMO of Leonard Homes, and we've been very active in helping our employee, we call them associates at Leonard, to access the GLP-1 medications. We have with diabetes and obesity, about 2,000 associates who are using them, and we're 11,400 employees. We were looking for a partner in our program, and the three finalists were Vida, Form Health, and eMed.
Okay.
I was trying to find out what was the fraction of, for each company, of the participants who were actually receiving a GLP-1 medication. And first of all, it was not very easy to find, even using Claude and ChatGPT. But I figured it out. So for Vida, it was less than 20%.
Okay.
For Form Health, it was about 45%. And for eMed, it was more than 75%. I'm just wondering, how do companies that are supposed to be helping employees with issues of obesity or diabetes can justify that only less than 20% or 45% would actually eligible individuals according to the FDA criteria where actually I can be actually receiving the medications, when we all know that only the medications will provide all the benefits, cardiovascular, etc. I'd like to have your opinion on it.
I think that's a good question. I'm going to rephrase the question. So how can we expect employees to be adherent and use the medication? And
no. The question is knowing what the benefit of this program is, which is to get the medication.
right.
How can companies that are helping employers justify the fact that only less than 20% or 45% of the employees who are eligible according to the FDA criteria would be able to access the medication?
Oh, I don't have a good answer to that question. Yeah, and it's one of my frustration points as well. So the specific answer would be employee activation. And how do you think about different, what we call points, you just named point solutions. How do we have point solutions engage individuals that have been identified according to the FDA guidelines? That's been a population health question that I'm sure Sarah can speak to as well. It's like getting individuals to be adherent to this, like I spoke about earlier with Crestor, Lipitor, and any other ones. It is an intrinsic motivation to want to take care of your health is the hardest thing to solve for. And I haven't found a point solution out there that does it optimally yet. I just haven't.
Needless to say, we went with eMed.
This may be a point solution where you don't want 100% participation. You've provided it as an employer. What your membership decides to do is in their best interest, because the higher you get to that 100%, once again, that's where the cash starts to flow away from you, particularly based on BMI level.
Absolutely. But to his point, though, of those that have been identified that should be actually on it and it would benefit them, how do you get those individuals engaged? That's the unsolvable question. He talked about behavioral economics when he was up here earlier today. I mean, there's some smaller companies that are out here that do it well for a certain what we call personas, but for a full population has been identified, we haven't found the silver bullet to that.
We have time for like one more question.
They've reached their max.
when you see most of the companies, ones we're involved with, they cover not only for the employees, members we call, or their spouses. It's all about adherence. It's all about education. How do you best educate the spouses who more than 50% from our studies are using it, but they don't know what they don't know if people don't tell them, i.e. husband, spouses coming home, right? So any thoughts on educating the spouses on the value of these and the use and the adherence?
So he just set this up for me perfectly. Any of the clients that I have, when I ask for show us your engagement rates, I want to see them for covered employees, and I want to see it for family members and dependents as well. I want separate reports. I want to see that you have a consumer activation plan that equally engages both the employee and the other members of the household. And most vendors won't even, point solutions won't even separate reporting like that. Of those that do separate the reporting, I make that a mandatory component of it before we sign any SOW. A little bit of a sneak peek, historically, the spouses are more engaged and more adherent than the actual employees, for the record. And a lot of times, anecdotally, not empirically, when you see the success of the spouse, that's when you get the employee engaged. And so I do think there's, again, going back to behavioral economics, I do think there's some behavioral persuasion that comes into place there when you look at that. But to take away from this, for the benefit managers in the room, make sure your point solution vendors are providing you monthly performance reporting showing that they're engaging the identified people, both the employees as well as the members in the household, because most of the time they're not.
Great. Well, please join me in thanking Doug for all of his information.